Hello. About 3 weeks ago, I started to work on this talk. I had read about TED Talks, I had watched a lot of videos, and so I thought what I had was perfect. So I recorded it, and I went for a run, and I listened to it on repeat. And honestly, it was terrible. And then it hit me. Zach, just tell your story. Talk about what you've gone through, what you're doing now, and where you're going. So hi, my name is Zach Schroeder, and this is just a little bit of my story. What do you see when you picture a road like this? Maybe it's a road trip with the family. Maybe it's freedom. Maybe it's the storm brewing in the background. But to me, it was a part of a 1,200-mile round-trip journey to MD Anderson in Houston, Texas. I'll never forget the moment I knew something just wasn't right. I was actually in my sophomore year of college at the University of Kansas, sitting just over there in Budig Hall, when I just broke down in tears in the middle of my genetics exam. I had been, for the previous month, losing weight, not feeling well, just overall generally tired. It was June 4th, 2019, that I was diagnosed with stage 3 melanoma. There was no cake, no celebration. It was my birthday, my 21st birthday. So except for the next 3 weeks, I was scheduling CTs, scheduling MRIs, and this is my PET scan. At MD Anderson, I followed with surgery where they removed 50 lymph nodes. I had 12 rounds of immunotherapy and 5 rounds of radiation. And then came COVID, and suddenly I had to do it all alone. The treatments, the infusions, the doctor's appointments, and no one to sit beside me when I asked, is my cancer back? Is it in my lungs, my brain? If it is back, how much longer do I have to live? For me, I'm from a small town of 8,500 people in southeast Kansas. And it was because of my people that I had the support. In the deepest and darkest moments of my life, I received phone calls, texts, emails, and letters from the folks back home. And nothing more that I want to be than back home with the people that made me feel safe. I wanted to be in my own bed, at my own kitchen table, surrounded by the friends and family who made me feel safe. You see, cancer is supposed to be the fight of your life. But if you're from rural America, your fight starts before you're even diagnosed. It costs us more time, more money, more memories, and overall, more resources. If you get cancer in rural America, you're more likely to be, 1, diagnosed later, so it's harder to treat. You're more likely to be uninsured or underinsured, and you're more likely to have a worse outcome, not because you're sicker, but because of your zip code. And if we look at this graph, this is what we call the rural cancer gap. And so we're graphing mortality rates since 1999. And we see that this graph is widening, rural versus urban. And mortality rates are death rates from cancer specifically. And you'll see that rural is falling behind urban and that this gap is widening. Nearly 1 in 5 Americans live in these areas. Yet only 3% of oncologists practice in these rural communities. 10% of oncologists practice in just 3 counties in the United States. In medicine, it is one of the most concentrated specialties, yet it is the second leading cause of death. And here's the nuance we don't talk about enough. Not every rural patient needs a highly specialized oncologist for every visit. What they need is a general oncologist, someone close to home who knows their name and knows their story. Yet the current system funnels patients to large urban cancer centers. And the truth is, we need both. We need the highly trained or highly specific oncologists at the tertiary and quaternary cancer centers, but we also need general oncologists practicing in local communities and saving lives close to home. Even when you find a doctor in rural America, and specifically rural Kansas, they're stretched thin. In a publication I am working on that I hope to put out there later this year, I found that the rural provider in Kansas, patient to provider ratio is over 500 to 1. In urban areas, that ratio is closer to 80 to 1. In hospitals, they're closing. In the past 10 years, 140 hospitals have closed. And they project that in the next 10 years, there are 600 more that are at imminent risk. Cancer care accounts for anywhere between 30 and 40% of hospital revenue nationwide. Yet increasingly, that vital source of income is bypassing rural hospitals diverted to large urban cancer centers. This shift doesn't just leave rural patients driving several hours for life-saving treatments, it is stripping rural hospitals of the revenue they need to stay afloat. And like I said, hospitals are closing, and they're closing at a rate of 2 per month. And by stripping them of their oncology services, a key pillar to sustainability, we're not just centralizing care, we're accelerating collapse. Clinical trials save lives. They are the new treatments on the block. Yet only 2% of clinical trials are offered in rural areas. Most of Kansas is what we consider a clinical trial desert, meaning you can't access a clinical trial. I have a friend who was diagnosed with stage 4 colorectal cancer. The standard lines of treatment just weren't working. His only option was a clinical trial. To get to that clinical trial, he would have to drive 4.5 hours one way to Duke University Hospital. Now, 10 years later, his disease is stable. He's living and he is advocating for rural patients and rural clinical trial access. So what do? Let me offer 3 solutions. Number 1 is policy. We need to expand Medicaid, period. We also need to support rural providers with loan forgiveness and flexible training so that they can practice in rural areas. And we need to decentralize clinical trials by providing mobile units to rural communities to be able to screen and do this through teleresearch, telemedicine, to get clinical trials in every clinic in every county in Kansas. 2, we need to change the narrative around our rural cancer patients. We need to stop treating them as someone else's problem, and we need to value them. They need to be able to eat at their own kitchen tables and have a hug from their grandkids whenever they get home. And 3, technology innovation, which is real and it's happening. And through those models, we can do a hub and spoke model, which is rural or urban centers can support rural clinics by extending the reach of care. And we need to empower community navigators and community health workers with technology to help them extend their reach of care as well. One model I am proud to be part of is the Rural Oncology Home. It is a framework for providing high-quality, team-based care in rural communities. What we do is we partner a patient with a local provider, and we leverage telehealth so that they can access the highly specialized oncologists in the big urban centers. And we also connect them to a community navigator of trust in their rural communities. And through this, we ensure that the road to treatment doesn't always lead away from home. So why does this matter so much to me? Because I've lived it, I've felt it, and I've survived it. Let me get on with my story. My 27th birthday is in just a few months, and at that time I will be 5 years cancer-free, a milestone. And in just a few weeks, I graduate from the University of Kansas School of Medicine, and I'll be going to Wake Forest to pursue a career in internal medicine and then oncology after that. And my dream is to be a rural oncologist. And when I tell people that, they say, that's not possible. You can't do that. There's no support. That's not a dream, that's a nightmare. And I tell them, yes, we can, and yes, we must. Because I've had cancer scares, even during medical school. And every time I have one, I remember what it felt like. And I know deeply what my patients need. I feel what they are feeling. It's mentors like Dr. Wade Swinson, and Dr. Josh Pritchett, and Valerie Davis, and Dr. Fu Trong, who have shown me that this road is possible. So now when I see Highway 69 through rural Kansas, I don't just see the road I drove at one time. I see the patients we're leaving behind. And I see the road ahead. We don't need to build new highways. We just need to clear the highway, or we need to clear the barriers from the highways that already exist. And I'll be on that road, not just as a doctor, but as someone who has walked it before and refuses to let anyone else walk alone. Thank you.